Well, we're at 10 after the hour, so we'll go ahead and get started. So welcome everyone to our next poster session for Society for Digital Mental Health. I'm Stephen Schuler. I'm a faculty in the Departments of Psychological Science and Informatics at the University of California, Irvine. I'm also the secretary on the board for the Society for Digital Mental Health. So want to just really thank everyone for their attendance and um, especially to the presenters today for your willingness to share your research. So if you haven't been to one of our virtual poster sessions yet, they go really fast. So we'll have 7 presenters in this poster session. They'll each give about a 2-minute presentation for their poster, and then we'll have time for a question or two after the presentation. I will let the presenter know who's going next in the chat, so to help people be on deck, and I will let you know when we can switch to your presentation. And usually we have a little bit of time also at the end for overall questions, and so if you're not able to get your question to the presenter during the poster session or during their sort of question time afterwards, you can hold the question. Can also say like feel free to put the question in the chat, and often our presenters are able to kind of loop back to the question after chats. And today's session is focused on user-centered design and community partnerships, and so the posters are really kind of focused on trying to think better about how to work with various parties and people to try to make our digital mental health interventions more impactful, more scalable, and more integrated. And to start off on that, we have Tatyana El-Kour, who's going to be presenting building practitioner capacity to apply user-centered design for enhancing engagement with digital mental health tools in Yemen. Take it away, Tatyana.
Thank you, Stephen, and thank you everyone for joining us today. So the challenge in Yemen is that mental health and psychosocial support professionals we're facing a lot of difficulties, and people are facing access issues, resources, and of course conflict. And that impact will of course impact the care delivery and the mental health needs continue to grow. And so the gaps is that the digital tools that are available are not really fit for the local context. They are not really in Arabic language. They do not employ user-centered design, so people do not feel engaged, or that as they interact with an app, that it's relevant to their context. And the key barrier was that practitioners really lack skills to adapt or create those tools. So what we did is we really wanted to look at how do you enable a scalable, user-friendly digital tool co-design opportunity for individuals. So this was through basically working with 23 local mental health and psychosocial support practitioners. They were employed, and we followed a 3D capacity building model. And the 3D really looked at a phase for discovery, and then design, and then deployment. So with the discovery, we focused on employing needs assessment. That was mixed methods. So quantitative and qualitative portions were employed to understand the capacity, but also have a baseline evaluation of where they stand in terms of understanding the user-centered design approach, but also the content generation and needs. And then the design was more of collaborative approach, so co-design of actual co-creation of the actual materials, and also the feedback loops, and curriculum and prototyping. And then the deployment phase is where the training took place and where the skill building approach was done with ongoing mentorship. The results were really impressive. So out almost in 3 key phases: learn, apply, and impact. So within the learning piece or the skill building piece, 92% of participants really have gained confidence in applying user-centered design. And the training really has boosted their ability to even create content that is relevant for the context that they work in. And within the application piece, where practically 92% have reported that they felt equipped to design tools aligned with their user needs. And the impact, even on looking into the relevance piece, was impressive, looking at 92% satisfaction rate. So the project really showed that locally driven, user-centered, design-informed approaches can really be essential in supporting digital mental health solutions, particularly in conflict-affected settings. I should note though, that this is a small sample size. It was a pilot program that looked at building the capacity of 23 mental health and or MHPSS practitioners. The digital access barrier was also huge in some of the areas of highest need, and there was a need for ongoing mentorship, and the impact linkage was actually, we will need to better connect the training outcomes to measurable improvements in mental health. And over to you, Stephen.
Awesome. Thank you. Well, thank you for the very nice presentation poster. It's really great to see the work you're doing in human-centered design. We have time for maybe one quick question. And Yiyang, if you want to work on maybe shifting to your poster as we take the questions, that would be great. Any questions for our presenter? I have a question, just curious, maybe if you can talk a little bit more about where you got the participants and, why their views, given the sample size, are the ones that kind of are important to sort of understand the potential for human-centered design in this context.
Yeah, so it was part of a consulting project. So we did a stakeholder mapping, and unfortunately, there were only 23 MHPSS practitioners in operations in Yemen at the time that we did the project. And so they were a mix of public and private, and also non-international NGOs, and some of them were local or civil society groups. So stakeholder mapping was done in advance of the actual employment of or deployment of the project, if that clarifies it. It was done through an INGO called Radar UK, and then a local INGO called Court Aid, along with the civil society organizations inside, in consultation with some of the public officials too.
Sounds great. Well, we're gonna have to move on to Yiyang. I see Eduardo has a hand raised. So Eduardo, if you want to if you have a question in the chat, maybe we'll have some time to loop back to it, or Tatyana can address it in the chat. But now we have a Yiyang Zhang from University of Virginia, who will be examining how mental health symptoms and demographics predict user experiences of mobile cognitive bias intervention for anxiety.
Hi, everyone. So my name is Yiyang. I'm an undergraduate at the University of Virginia, and this is my research with the Program for Anxiety, Cognition, and Treatment Lab. So as you might know, anxiety is a significant issue on college campuses. Studies show that nearly 42% of students and 39% of faculty report experiencing severe anxiety. So to help address this, our lab developed a mobile mental health program called Who Think Calmly, specifically designed for the UVA community, which allows users to select potentially anxiety-inducing scenarios related to everyday stressors such as academic or career pressure and social situations, and uses cognitive bias modification for interpretations, or CBMI, to help reframe them in more positive and flexible ways. So for example, if you see a friend in the distance and they don't wave at you, do you assume they're ignoring you, or consider that they might just be distracted? Who Think Calmly encourages users to stay open to this range of possibilities instead of immediately jumping to negative conclusions. But one challenge with CBMI and many other digital mental health tools is user attrition. So people often stop using these programs, which limits their effectiveness. My study focused on understanding which user-related factors, such as demographics, emotional health, or mental health history, might influence engagement and overall user experience. So we collected data from 95 UVA students, faculty, and staff using biweekly surveys measuring factors like helpfulness, relatability, believability, ease of use, and privacy concerns. And the results were promising. So 99% of users found Who Think Calmly helpful, and 93% found the scenarios relatable. These positive experiences, they didn't vary significantly by age, race, or baseline emotional health, suggesting the program's flexible design is broadly acceptable across different groups and levels of distress. However, we did find a notable gender difference. So women rated the content as significantly more relatable and believable than men. And while this may be partly due to the scenarios being developed primarily by female researchers, which could have influenced the program's tone or focus, there's also a broader social factor where men often place more value on emotional restraint and action-based problem solving, which may make the program's approach feel somewhat misaligned. These findings highlight the need for more male-centered design and further personalizing content to enhance the user experience at an individual level. Thank you.
Awesome. Thanks so much. You have a question in the chat already about if you want to, it could expand any more on like explanations for why you think you see this gender difference and why females are responding this way.
Yeah. So one thing is that, as I mentioned, that the most of the program was developed by female researchers in the lab, and so you could say something about how people like the stressors that the female researchers were talking about maybe didn't totally account for male participants and what they worry about or how they think that these situations would then be resolved. And so that was one idea, and then also just that in a lot of cognitive behavioral therapy and like emotion focused treatment, this more studies have found that it's like aligns a little bit more with women's preferred coping styles of being more emotion focused and expressive.
Awesome. Thanks so much. We're going to move on to our next presenter, which is Yiyang Kwan from Northwestern University, who's going to be presenting Enhancing Digital Mental Health, Young Adults Resource Needs, and an Automated Text-Based Suicide Prevention Intervention.
Hi, I'm Yiyang. And so current days, like we noticed that the suicide rates are rising among the US young adults and they face a barrier to mental health care. So we decided to like design the digital automated text-based suicide prevention program for them. And we find that personalization and customization can be two really important factors to enhance long-term engagement. And personalization defines a system-level decision that use algorithms in the text-based tool to tailor resource need. And customization is more of a user-level decision that foster a sense of user autonomy that allow the users to actively shape and control their experiences. And our study explores how young adults want an automated system to support their management of suicidal thoughts and behaviors. And 9 young adults with lived experience of suicide participate in the semi-structured follow-up individual interviews. And then the interviews were transcribed and subjected to thematic analysis. And 3 coders established criteria for the key themes, and discrepancies were addressed through meetings. So for our result, we found out the young adults, they found the automated digital safety planning can be like really helpful if it can provide them with the resources like psychoeducation about suicide-related thoughts and behavior, localized resources, stories about others with lived experience, and other mental health resources. And this is a cloud theme that like is based on the frequency of these themes, the like how many times these themes like appear. So psychoeducation is the most identified one by almost like all the participants. And so to conclude, it is crucial for a personalized digital intervention to incorporate the user's need using the algorithm such as decision trees for providing tailored resource. And embedding an automated crisis detection tool can be really important to ensure timely and relevant resource delivery. So for some of the limitations, the study has a pretty small sample size and focus on the young adults that can limit the generalizability. And additionally, the study relies on an imagination-based exercise that participants, they did not actually interact with the suicide prevention tool. So their identified preferences might be differ from like their actual preferences. Thank you.
Fantastic. There's a question here in the chat for you. Any insights on whether participants wanted the tool to ask questions about suicide directly? So for example, are you thinking of killing yourself versus indirectly due to different, cultural differences?
Oh, this is a really good question. So I think it's so in our tool, it's like because the participant they already identify the thoughts like somewhere in like other service and all that. So it's mainly focused on like the safety planning part. For example, we identify the warning signs, coping skills, people for distraction, and those kind of things. So and when we are like addressing the thoughts, I think we would say more of like, are you planning to do you have like any thoughts of killing yourself or like thoughts of suicide in these kind of ways?
Awesome. Thanks so much. I love seeing some chat and some chatter in the chat. So, and I saw some questions that maybe across presenters we'll be able to loop back to if we have some more time at the end. But we will move to our next presenter, who is Taylor Myers Brower, who's going to be from the University of Virginia, who'll be presenting user perceptions of a culturally tailored digital cognitive bias modification for interpretation program for anxious Hispanic individuals. Taylor, take it away.
Thanks so much. I know it's a bit of a mouthful. This project was sort of driven by our goal of trying to address mental health disparities among Latinx Spanish-speaking individuals with anxiety. We've, for a long time now, had a CBMI program that Yiyang spoke about available within our lab. And so our goal here was to adapt it to make it more accessible by making an app rather than a web-based version, as well as integrating some features and making some changes to make it more relevant to the Latinx community. Our original app development was kind of based on feedback that we had received from a web-based version of our program called Mind Trails. So we had a good starting point. And once we had a good prototype built, we invited many folks to do interviews with us. We only got 11 Spanish-speaking adults that wanted to give us feedback, so we're still working on that. But they were able to play around with the app for a little bit and help us get some ideas for ways that we're not quite hitting the mark on making this culturally relevant and some ways that we can continue improving. And then we did a qualitative analysis. It was a very iterative process, making changes to our code book throughout each of our interviews. In terms of our sample, we had predominantly a female sample, which was unsurprising, but we had a really nice age range. And to the question in the chat, we did have a big range in digital literacy. We did recruit from newspaper ads. And so we had 2 folks respond to a newspaper ad, and they had no experience with apps and had to get assistance from their children to participate and contact us on Zoom. So I'm happy to answer questions about that. And then we had a big range of anxiety symptom severity. I can zoom in on this so we can see a little bit about the results that we had. We got a lot of feedback about sources of confusion, ideas for how we can make the onboarding process more smooth, especially given all of these variations in digital literacy. A lot of ideas for ways that we can make the program more tailored and more customizable, both at the individual level and giving folks choice in how they interact with the app, as well as at the cultural level. So more ideas for how we can integrate dichos or Spanish phrases that are really relevant, thinking about how we can approach the fact that there's big variations across different Central and South American countries in the terminology that they use, the phrases that are relevant. One thing that we were really curious to learn about was ways of handling experiences of discrimination in a way that wasn't trying to get folks to question whether they interpreted that situation correctly. So we got some nice ideas for what folks were hoping to see. And interestingly, almost all of our participants were seeking some form of additional education, whether that was related to experiences of discrimination or about what anxiety is, what their personal triggers of anxiety are, how they can monitor symptoms over time. So it gave us a lot of ideas for some of that foundational information that folks might need, and other features that we might be able to build in. But overall, folks had really positive experiences of the app, are really excited to use it and feel like it fills a void sort of in the available apps for mental health treatment. But again, we had some difficulty with recruitment, and folks weren't using this app as intended in a full trial. We want them to use it daily for 6 weeks. They used it for maybe an hour, so taking into account the fact that they didn't necessarily have the opportunity to get full exposure to the repetitive experience of it. But we're really excited to continue doing this work and building a new revised version that we can launch in a full open trial.
Sounds great. I saw a question in the chat already. What were some barriers you experienced in recruiting people to complete the interviews?
Yeah, we're having an interesting time trying to figure out what the issue is. We did snowball sampling, we did social media posts. We did have a good number of folks respond to the ads and then losing them in actually enrolling them and getting in touch with them. And some of the barriers, I think, are that a lot of folks had international phone numbers, but then would request text messaging and wouldn't provide an email address. And so we had no ways of getting in touch with them. So making adjustments to just like our Qualtrics interest form to be able to require the information we need to get in touch with them. The next question, authentically inclusive versus... Oh, that's
I'll just note as you answer that question, maybe Phoebe, if you can start sharing your poster, that'd be great to help us move. But yeah, Taylor, if you could answer that question, that'd be great.
Oh, I failed to mention that the other researchers, and I'm very white, the other researchers on our team are Latinx individuals who are bilingual, and so they were the ones conducting the interviews. So I was involved in the process of designing the study, but less involved in the actual interviews and trying to solicit this information from folks. So that was our big way of trying to overcome that barrier of seeming like outsiders trying to infiltrate a community and use them for research purposes, but rather identifying with the community and understanding like, yeah, I have also experienced some of these barriers. So I hope that answers that question.
Sounds great. Awesome. Thanks so much. Our next presenter is Phoebe Holtz from Massachusetts General Hospital, who will be presenting patient versus clinician impressions of symptom improvement in app-based CBT for OCD.
Awesome. Yeah. And can you see my screen okay? I'm having trouble
Yep,
seeing.
can see it great.
Awesome. All right. Yeah. So today I'll be presenting this, which is a secondary analysis of the treatment group in an RCT that followed 60 participants enrolled in a 12-week app-based CBT treatment for OCD. And we're looking particularly at concordance between clinicians and patients' impressions of symptom response. So just a little bit of background. The gold standard treatment response measure for OCD is pre to post change in a clinician-rated interview called the Y box. But because it's a clinician-rated measure of symptom severity, it's sort of unclear how well it corresponds to participants' own experience of their symptom improvement across the treatment. So we're looking at 3 measures in particular. The first is a clinician-rated measure, the Y box, at pre-treatment, so week 0, and post-treatment, or week 12. The second is a patient-rated measure, the OCSRS, also taken at pre and post. And then finally, we used a modified patient-reported version of the Clinical Global Impression Scale, the CGIP, which we gathered at post-treatment. And it was essentially just one question asking patients to rate their OCD symptom response to treatment on a scale of 1 to 6, with 1 being very much improved and 6 being very much worsened. So overall, we did find kind of high concordance between patients and clinicians, which was great. So for both patient-rated and clinician-rated symptoms, we saw about a 30% reduction in symptom severity by the end of treatment, and the change in these 2 measures was highly correlated. So sort of in terms of self-reported symptom change, that seems highly correlated. And then we also saw a high correlation between reduction in symptom severity, both as rated by patients and by clinicians, and post-treatment CGI scores, so their own impressions of symptom improvement at the end of treatment. And because we were particularly interested in beginning to understand sort of what's driving differences in patients' impressions versus clinicians' impressions when they do differ, we broke symptom change down by different types of symptoms, and we saw that particularly a change in obsessions predicted sort of a high correlation with post-treatment impressions of improvement. So a greater improvement in obsessions is especially associated with a greater overall impression of symptom improvement by the end of treatment. I'd say that overall these findings were pretty reassuring. It's great to see that the gold standard measure was also capturing patients' own impressions of their improvement by the end of treatment. And then in terms of future research, I'd love to look sort of specifically at cases where clinician ratings did not align with patients' own reports and seeing what might be driving this discord sort of in those cases.
Very good. And very succinct presentation. I really appreciate that. Questions? I mean, I'll ask a question because I think this is super interesting, and in my own work, I've gotten really interested and perplexed sometimes when some of the different data gives different answers to improvement. I'm curious, like, how you would think about following up and trying to unpack these instances, as you mentioned, where maybe there is some discordance between what a patient says and what a clinician says.
Yeah, I'm definitely, so we've been brainstorming kind of potential demographic factors in particular that might be driving that, as well as sort of symptoms that are changing. So if patients are reporting sort of a big change in how much they're resisting their symptoms, but not an actual change in the symptoms themselves, that could lead to sort of a lower score on the clinician-rated measure. But patients might say, well, you know, I'm trying so hard to resist my symptoms and I'm not actually experiencing any relief. So that's one avenue. Another might be, you know, even just like baseline demographics. So things like race, age, gender, and those are all going to be things that we're hopefully going to look at in a follow-up sample.
Yeah, and I'll say, like, in some of our work, we found with some qualitative work that the sort of benefits that people were reporting were things that we weren't measuring. And so I think it also, like, I think raises some interesting questions about what we should be measuring in these digital mental health treatment studies? And then also, are there more sort of proximal factors we're moving before we're actually moving clinical symptoms that they might be seeing, more changes? So that's really awesome. Cool. Thanks for the amazing presentation. So next up we have Erudadi Nagrandra from the Schizophrenia and Psychosis Action Alliance, who will be presenting on exploration of negative symptoms and digital application use in people with schizophrenia.
Sure. Hi, everyone. My name is Arun Nagendra. I'm the scientific director at a nonprofit advocacy organization called the Schizophrenia and Psychosis Action Alliance. We partner sometimes with industry or pharmaceutical partners to bring kind of the lived experience perspective to their work. So what I'm going to talk about today is what's called a prescription digital therapeutic that was designed for people with schizophrenia. A prescription digital therapeutic is basically a digital app that has been reviewed by the FDA for safety and effectiveness, and once it's approved, can actually be prescribed by physicians, which is pretty cool because it, for example, can be covered by insurance more clearly and things like that. So it improves, the idea is it might increase access. The particular type of symptom we looked at here was negative symptoms in schizophrenia. So most interventions for schizophrenia treat hallucinations and delusions, but they don't treat these symptoms that are actually really predictive of a lot of outcomes, like having kind of like flat affect, or like talking in a monotone, or not feeling very motivated, which are really core symptoms of schizophrenia. So they've developed an app to kind of treat this via CBT interventions that are known to be effective, but are not widely disseminated. And our goal was to like interview folks with schizophrenia to understand how they feel about negative symptoms, how they talk about them, the language they use, and whether they'd use prescription digital therapeutics. This is a very like busy poster, so I'm just going to walk through some quick highlights here. We did like a survey where we asked like several questions about use of prescription digital therapeutics, and then we picked like with 49 people, then we picked like an enriched sample of about 28 folks, and we focused on prioritizing ethno-racial diversity in this sample. Here are kind of like the big takeaways. First, people with schizophrenia, even people who've been diagnosed for a really long time, did not use the right, did not understand the terminology that we use to describe these symptoms. So positive symptoms refer to hallucinations and delusions, things that are added onto typical experience. Negative symptoms refer to things that are missing. People understandably interpret negative symptoms to mean like things that are not very good for my life. And so even like what the intervention was targeting was not very clear to people. But once they understood that, they really were excited about getting treatment for it. They said they really needed that treatment. They said they were feeling really lonely and disconnected. And so we asked them to what they thought about kind of using technology, because I think there's a perception that people with schizophrenia don't, may feel like too paranoid to use technology and things like that. That's largely not been borne out by research. Our findings are pretty consistent with prior research. 98% of our sample used smartphones, 40% used like health apps. They wanted to use these things, and they were generally like they really were they really wanted kind of like support with their negative symptoms, and in particular wanted to focus on kind of like social connection. And so really what this kind of pulls out is like, one, we need to be able to describe in kind of like lived experience centered language, like what this app is about to treat. And two, like, there are a lot of people who are really kind of wanting support with this untreated type of symptom. And so this is a pretty promising intervention. Thanks, everyone.
Awesome. Thanks so much. I want to plus one a comment that Tyler made in the chat. I really appreciate the explanation of prescription digital therapeutics and digital therapeutics. I think it hits a theme that I've heard in some of the different talks at the conference, which is that digital mental health is a kind of evolving space and a growing space, and there's a lot of different things out there. And I think getting kind of clear about some of the sub areas in here and prescription digital therapeutics and what that means is really useful. So thanks for sharing that. Any questions real fast? I think we have time for a question.
Sorry, I was trying to find the button. Yeah, really great work, and really exciting to see somebody focusing on negative symptoms. I wondered, as far as developing the intervention, were you using people with schizophrenia's lived experience in sort of formulating the probes and the way that the questions were asked and this sort of thing too. That's a tricky area, I know.
Absolutely. So we have a peer. So for the app itself, we did not create the app. That was Behringer Ingelheim, and they did have kind of like a co-design strategy with that. I'm
Okay.
not too familiar with what they did. For us, everything we do, we have like a peer advisory committee and a family advisory committee. We run all of our questions by them, all of our like research materials by them, and kind of get their feedback on it. So we're pretty consistent with that. But that wasn't particularly for the interventions.
Excellent. Okay, thank you.
Awesome. So now we have our last presenter in the session. So we have Rehan Taher from the Department of Psychosis Studies at King's College London, who will be presenting the safety of digital mental health interventions, finding recommendations from a qualitative study exploring users' experiences, concerns, and suggestions.
Thank you, Stephen. Hi, everyone. My name is Rayan, and as Stephen said, I'm a PhD student at King's College London. I'm excited to be here with you today and present to you one of my PhD studies around the safety of digital mental health interventions. So as you're aware, digital mental health tools like apps and chatbots are now more common, and the question of safety is becoming increasingly important. Till now, research has focused mostly on the technical and clinical perspectives, but research on safety is also growing. However, there is no known research around the voice of users themselves and what they think around the safety of digital mental health interventions. So we're presenting to you today our qualitative study that we did with 15 users that have used digital mental health interventions to explore what their concerns, experiences, and suggestions were for the safety of these tools. We found from users that the three main concerns for them were first what we call non-response. So the idea that sometimes you use a mental health intervention, but actually it doesn't help you. And that's a big risk because it stops you from seeking out another treatment that could have been effective for you and helpful. The second one was a term called symptom deterioration, which is common to also face-to-face mental health interventions. And it's the idea that sometimes when you go through therapy, you have to talk about things that are uncomfortable and sit with feelings that are uncomfortable. This is a bit more difficult in digital, especially with those that are completely self-administered and you don't have a therapist working with you that can support you through these feelings. And then finally, but not surprisingly, data privacy concerns, where many users had concerns about how their data was being used. And this is a big concern, given that we also found that many interventions are not great when it comes to data privacy. And if they do have a policy, it's usually in their terms and conditions, which are very long documents that people don't read. Now, based on what users told us, we developed 7 practical and user-informed recommendations to improve the safety of digital mental health interventions. These were all found in the paper, but these include making safety and privacy information clear and easily available to users, easily accessed, not just in the terms and conditions, making scientific findings present in lay terms, maybe even bullet points, acknowledging the limitation of the technology that we're using and not over-promising on how curative it can be, offering real-time feedback on progress to users so they know how well they're doing compared to other peers or what's expected out of that treatment, and ensuring that crisis support feels genuine and human to them and not just a boilerplate that's used everywhere. At its core, this work reminds us that the safety of digital mental health is not just about preventing harm, it's also about fostering trust, emotional support, and a sense of being truly understood. It is important that users feel that these interventions genuinely care for their safety so that they can use them to get the benefits out of them. Thank you everyone for listening, and I'd love to answer any questions.
Awesome. Thank you for a really great presentation. And I'll say this is something that I worry a lot about, which is that we don't know enough about sort of safety and concerns in these products. And so I'd be curious, I really love the recommendations you have for like digital mental health, but for like products, but like I'd be curious if you have any advice or recommendations for researchers as they try to better understand safety concerns or negative consequences in their digital mental health trials, because I think often we don't know about those because we don't ask.
Yeah, exactly. And I guess the answer lies in that question, right? It's to start treating safety as a primary outcome in your research. The way they do it in medicine is that they look at benefit and risk, and then something is good enough when your benefit outweighs your risk. But in a lot of mental health research, we don't actually collect any data on risk, or we assume that if nothing has happened or has been spontaneously reported to us, that something is safe. And that's not a fair assumption. I think, yeah, my one recommendation to researchers would be actively go out and ask your participants about risk. That could be with things like the negative effects questionnaire, and that's a questionnaire that's been designed particularly for mental health interventions, both face-to-face and digital. It will tell you what risks people are experiencing, how severe, and whether it was caused by your intervention or not. If it's a product that's like regulated or seen as a software, as a medical device, you could go a step further and collect adverse events and kind of do some analysis to see if your product is safe.
Awesome, thank you. There was another question in the chat. Is there a particular ranking to the priority recommendations that you have identified to address safety issues?
No, I'd say all of them, because the field is, still starting to kind of solidify. I would say all of them are quite basic and fundamental, and nothing is kind of extra or bonus. So if they can all be applied, that would be great. There's not an order or something that's more important than the other.
Fantastic, great.
Thanks for
So we have a little bit more time, about 15 minutes left for overall questions. So I'll actually start. There was a question earlier in the chat that I would say for all presenters. So if any presenter wants to kind of go first, or if you're an audience member and you have experience from your own sort of studies you want to share in, like these sessions are meant to build community, build collaboration. But the question was, do you encounter varying levels of digital access and literacy among participants? And if yes, how do you address this? And I would maybe add on a little bit. I'm also curious on people's thoughts, given some of the sample sizes of the studies you're presenting is, some of these are small samples. And so how do we think about like who we're capturing and maybe who we're not capturing as we think about digital access and literacy among participants? So any presenter, feel free to jump in.
I can share that. We kind of anticipated that there might be low levels of digital literacy, especially because we were choosing to recruit across such a wide range of physical and digital spaces. I think we could have been better at advertising that we are very happy to hop on phone calls with folks. That seems to be like the easiest way to walk. It happened with some of our participants, to walk them through the process of downloading an app and getting onboarded in a way that is very well received, and they're much more open to talking on the phone than pinging back and forth via email. So that was our main tactic, was being willing to invest the time in onboarding via phone.
Awesome.
I see two raised hands. Arundhati, I saw your hand first, so we'll start with you and then Tatyana.
Sure, I go by Arun. So I think that, I mean, this is an incredibly important question, and we think about it a lot in the context of schizophrenia. And some just kind of things I've learned, even people who are homeless with schizophrenia, the majority of them actually report having a smartphone. It is like kind of like such a like critical aspect of just like surviving, that people will have that even if they don't have a home or don't have a lot of other like staples. And this has been like borne out in research. I think like one of the really interesting aspects of this though is just kind of like access to the internet, like regardless of like digital literacy. We work with an organization called Rural Health America. I think they said that something like only 70% of people in rural America even have access like to consistent internet. And so I think there are a lot of those things that need to be considered. I really think like we just need to kind of do a lot of like stratification to understand like who has access and who doesn't. But I think like technology is so ubiquitous now that like for these apps, most people, even this group of people who generally like maybe wouldn't use it very much, according to what people might think, use it a lot. So
yeah, and I'll say I did some work in youth experiencing homelessness, and we found similar things, that smartphone access was pretty ubiquitous. But the biggest challenge we noted was data access, is that they would often like lose their cell phone plans and, not have periods where they changed their phone numbers. And so keeping track of people, but it was a very important lifeline for them for lots of things. Tatyana, you had a comment as well?
Yeah, I just wanted to bring more focus on the user-centered design piece, because I feel like with our experience in Yemen, a lot of them were really focusing on the digital access issue and then on the apps being irrelevant, when in fact, like, I was very surprised to understand from the practitioners while we were doing the context mapping and analysis that they really did not know the journey of their users or of the patients or of the clients. They don't know what their day look like. They don't know how they actually spend their time. They don't know what kind of tools they have access to or what kind of environment they live in. So I think the contextual analysis is really critical as you look into that. And then it's very important to do some capacity assessment, as we've done, and some baseline measures to understand where are people at from digital literacy and also digital access, and then how can you break those barriers to them in a different way. So one of the ways we've worked through is to have a common access point. So one of the folks have actually opened their own home that had a good digital access to allow people to come and actually be part of the process. And then other options could be explored using offline metrics or measures. But what was most important is the user, like the journey itself, and then what is the outcome of that journey, irrespective of the digital tool or not, if I may say.
Awesome, thanks. Other thoughts or other questions? Feel free again to, if you want to pose a question to one of our presenters or cross presenters, feel free to raise your hand, just unmute and jump in, or add a question to the chat.
I'm going to jump in here since there's a little bit of space. I'm Eduardo. I'm very excited for this work that you're all doing. My work is focused on the intersection of crisis care and peer support and suicide prevention, and really looking at this in the digital space. Very interesting. So I forget, sorry, who was presenting on the issue? It was Ryan, but anybody, I'm interested here. One of the things that we hear a lot about in terms of safety, so safety, who defines safety, right? That's, I think, a very interesting question in and of itself. And we had a webinar on this last week with a lot of people from around the country. But from your point of view, one of the things, what are the sort of the big concerns when it comes to somebody who's having a heightened distress, maybe having some suicidal intensity or something like that? Because working with the National Lifeline, like we hear a lot of things about, like, people are like, well, don't call those guys because they're gonna send the cops, right? So safety in terms of like personal dignitary safety, as well as sort of safety in the community, do people feel safe when it comes, particularly to some of these questions that are being asked? And Rayan, I don't know if you have any specific thoughts on that, but anybody obviously would be interesting to hear from.
Thanks for that, Eduardo. I guess I'm not familiar on that particular situation in the US, but I'll speak for our experience here in the UK. Is the kind of argument is that when someone is in therapy or is going to a clinic or a GP surgery or a therapist, then you are aware when risk is higher, and then you're able to intervene and provide support. But if someone is using an app and has no connection, then even if you are aware, which sadly not a lot of people are also measuring risk consistently, and maybe because they don't know what to do with that information. So sometimes the information is not collected, and if it is, nothing happens about it. But is that, how do you then reach that person and provide that support? The current thing is that when either people are getting referred to our example of the crisis line, which is Samaritans, and then kind of they just refer them to calling that line. The other thing that I think is maybe a bit more helpful is it's a bit of a blended support where the therapist or the family doctor or the GP is aware that this patient is using this app. And then they have someone who's called like a digital companion that calls the person maybe once a week just to see how things are going, assess risk. And then you have that connection, or at least the app is aware who the clinician is for this particular patient or user, so that if risk is detected, it can be escalated to a human that can then deal with it and see if there's something that they can do to minimize risk. I'm hoping that that was helpful. I know it wasn't specific to the example that you gave.
Yeah, very interesting. Thank you.
Does anyone else have any thoughts on that question? Any other questions? We have time maybe for one more question. Okay, if not, well, let's just thank our presenters again. The gal did a lovely job of presenting very clear and succinct and really interesting research. Just as a reminder, the next session, there's sort of three options. There's a virtual exhibit by Videra Health, a virtual exhibit by Atsuka Precision Health, and also a graduate student open house. And the graduate student open house is really aimed at current undergrads or post-bac individuals interested in pursuing a graduate degree. So, you know, that's the way to join with us in the next session, but there's still a lot more going on this afternoon. So again, thank you to all the presenters for presenting, and thanks for your attendance engagement at Society for Digital Mental Health so far. See you guys in some more sessions.